So first we move on to the hip exam. First thing I do when I'm evaluating a patient is I inspect the legs. I'm looking for any asymmetry and atrophy. And the first motion I do I just do, it's called a log roll exam. And I'm comparing both sides and I want to see how much motion there is. I'm looking at the feet to see if any one of them is stiffer than the other. And then I have the next move is to first I have extend the leg and I'm checking the flexibility of the hamstring, whether this is difficult or not, and it's very easy here. And then I have Peter hold the leg right where it is and I push down. This is called the Stinchfield exam. And what I'm really doing right here is I'm irritating the femoral acetabular joint. I'm causing pressure in that joint to see if that generates pain. And sometimes I'll do it, I'll hold it there, push against me, Peter, and then I'll palpate in the area to see if that hurts. And sometimes pain in the front of the hip can be related to a strain of the muscle, or sometimes it's a problem deep inside the joint. If it's deep inside the joint, it doesn't really hurt to push in that area. If it's a strain of one of the hip flexors, it'll be tender in that area. For example, the rectus femoris will be tender there, and sometimes even the iliopsoas, but that's a little deeper of a structure. So after I do that, I have Peter bend both of his knees. Peter, I want you to touch your pubic bone right in the front. This is where I'm checking to see the abdominal wall musculature. Some people develop injuries where the muscle attaches to the pubic bone, and I have them try to do a little bit of a crunch or a sit-up. Sometimes I have them elevate their legs straight up in the air to see if that generates any pain. Does that cause any pain?
Nope.
Good. So then I'm working my way lateral. I'm going to have Peter adduct, adduction of the hip. I'm going to have him flex both knees, push in toward the center. Does that hurt? Sometimes I'll palpate in the adductor musculature, push into the center. Good. Any pain there?
No.
So this is anterior groin pain. I'm looking for the adductor muscle. I'm looking for the abdominal muscles to see they're attached to see if that generates any pain.
Now, how are you able to differentiate between if I just have a strained adductor, which would hurt very much if you did that because I've been in that pain before, um, versus a problem in the actual acetabulum?
So they both may cause pain, typically because I've done that other maneuver, the Stinchfield test. That's not going to necessarily hurt the adductors. So if that hurt and this hurts, I have to sometimes do more than one exam. I'll have to do 1 or 2 or 3 exams to try to narrow it down because a lot of these tests are sensitive but not necessarily specific. So I have to add multiple tests to figure out what's happening. So then we just did adduction, pushing to the center. Now I'm going to have Peter do abduction, abduction, and I'm going to palpate along the greater trochanter of the hip. And the gluteus medius and gluteus minimus attached there. There's also a bursa there. And if I have him push against my hand, I want to see if that generates any pain.
And if it does, and it's not the muscle, which of course can also hurt, the TFL can hurt, the glute med can hurt, all these things can hurt.
That's right.
But is that going to produce a bony point tenderness on the greater trochanter as well, potentially?
It will. So for a tensor muscle strain, it doesn't usually hurt right on the bone, but a gluteus medius tear, gluteus minimus tear will, bursitis over that area will. And so again, it's one of those things where if it hurts there, I'm not done. It hurts in a lot of people normally too, even without any pain. People often are tender in that area. You know, we see that with the coracoid too. There's certain times when you palpate and it hurts. I have to check the other side and I say, well, does that hurt too? And oftentimes it hurts and it's just a tender bony prominence. Okay, so then I want to check motion of the hip. The first thing I do when someone is in the supine position is I do something called circumduction, where I'm bringing the leg around. I'm bringing the head internal rotation, flexion, abduction, and extension. That sometimes will cause popping of a tendon called the iliopsoas tendon in the front of the hip, which could be absolutely normal. If it's painful, it may indicate some pathology of that tendon or even potentially some instability of the hip, like we see sometimes when we manipulate an unstable shoulder. So next, we move on to internal rotation. Internal rotation of the hip, I bring it to 90 degrees, and I'm comparing internal with external. He's got very even internal and external rotation, and then I will check that on the
Now you're
contralateral hip.
not really torquing on me as much as I
No.
would torque on me. So you're doing this in a very gentle way.
Correct, because I'm not trying to stress the joint.
You're not trying to go to max.
I'm not. I want to see when I have a feeling, sort of a feedback of what is sort of the normal, comfortable range of motion. The other thing is when I'm examining somebody who's got a joint problem, their hip hurts and I torque on it, I'm done. I won't be able to really test anything else because everything I do will hurt. So it's important not only to do that in a sort of a gentle way, but also if I'm suspecting something in particular, I do that last. So this is sort of a normal progression if we did everything, but I will change the order of the exam based on what I think it is, based on the history that I took, based on the gait exam, based on the standing exam.
In general surgery, we would do the rectal exam last, just for that reason, I think.
So you can leave right after.
Yeah.
Yeah, exactly.
Why put them? Yeah. Why upset everybody at the beginning?
Same thing. So okay, so now this is a part to your point, where I will stress that motion a little bit. It's called the Fadir test at flexion, adduction, internal rotation. And there's also something called a scour test, where I'm trying to see if this elicits any pain. What I'm doing is I'm rotating the femoral head and the neck in the acetabulum, the cup, to see if that irritates the labrum specifically. And sometimes that'll be indicative of not only a labral tear, but of something called femoral acetabular impingement. Also in this position, I go straight up and I flex the hip. Sometimes that will cause some impingement in the anterior inferior iliac spine, which is another structure of the pelvis, which sometimes causes pain. So this is called the scour test or the FADIR, where I'm just seeing if that generates pain. From there, I move to the Faber test, which is flexion, abduction, and external rotation. And what I'm looking for is to see how far the knee will flop down. Will it go all the way to the table or is it elevated? And I sort of, just as a general rule, I'm sort of seeing how many fists I can get under there. If it's less than one fist, sometimes that will indicate some laxity of the joint. If it's more than two fists, sometimes it may indicate some tightness, which may be a capsular problem or some muscle tightness, but sometimes it's also arthritis of the hip.
And if it's muscle, is it mostly the adductor?
Yeah, it's because that's what's sort of stopping it.
Yeah.
We see less of that for this particular motion. Oftentimes, I'm really thinking about arthritis in that area or some sort of instability if it's too loose.
Mm.
And then the other thing is
that would be in a labral tear. Would it be too loose potentially?
It's a little different than the shoulder in that regard because of the socket is different. So there are certain individuals who have very loose hips, and that's due to developmental problems. It's often due to what their activity is. Ballet dancers, for example, are incredibly flexible, and so their hips will come all the way out, which, there's a difference, just like in the shoulder, there's a difference between instability and laxity. So instability is more of a symptomatic laxity. And I'm also comparing to the other side, and if there's any difference, and this one comes down a little bit more, but again, if it's not generating any necessary pain, I'm not necessarily too concerned about it. Okay, so we did internal rotation, external rotation, a little bit of abduction motion. Now, Peter, I want to have you sit up because I'm going to check the flexion and extension of your hips. So I'm going to have you sit all the way at the very edge like you're about to fall off. Keep coming, keep coming. I'm going to want you to grab your left knee and lie down and bring it to your chest. It's called the modified Thomas test. And I'm going to just let your leg hang down comfortably. And a couple of things here. I'm looking at the angle between his thigh and the table. And if I push down, what I'm really assessing is how tight are the hip flexor muscles, in particular the iliopsoas. So he's a little bit elevated from neutral. Some people go all the way down. Again, depending on what the particular complaint is, there may be stiffness because of arthritis. It may be stiffness because of tightness of the flexor muscles, or it might be loose because of instability. And the other motion I'm checking here is to see the iliotibial band. So some people are easily go towards midline, some people pop back. And so this may indicate some tightness of the structures on the lateral aspect of the hip. And then I'll compare the other one. So you bring your knee to this side and let this hang. So your iliotibial bands are probably a little bit tighter, not much, and see if, and also I'm checking to see, can you just let your leg hang? Because that's about it. So that will give us indication of some quad tightness too. And also to see how much the hip is elevated compared to the table. Okay. So we got more to do. So now we move to the lateral position where I have you lie onto your left side. And so I get a first thing I do is I check the spine. I want to make sure that that doesn't hurt. I check the SI joint to see if that generates any pain. This is where I'll check where the sartorius originates from and the tensor muscle as well. And again, here's going to be another opportunity to check your abductor strength. So I'll have Peter lift up your leg and don't let me push down. Good. And it's a more sensitive test in the sense if you really have an abductor problem, this is hard to do. And this, relax your leg completely. So before we were looking at IT band tightness or tightness on the lateral aspect of the hip. And I want to see if Peter's knee can come all the way down to the table. And that's good. Good. So he's pretty good there. And also this is an opportunity we can check to see if there's any instability. Just like the shoulder, we sort of do this provocative maneuver where I'm pushing on the greater trochanter to see if I could push the ball forward. And if that's very uncomfortable, that will generate pain. And then I extend the hip in different positions to see if it's more comfortable. So as we adduct your hip, Peter, it's a little tighter than if we abduct and extend. And sometimes if that generates pain, it may be impingement in the posterior aspect of the hip. And that's where, palpation in the sciatic notch is important to see if there's any inflammation of the nerve or surrounding structures. Next, we go prone. And again, another opportunity to evaluate the spine. Again, greater trochanter and sciatic notch to see if anything's tender, and then the origin of the hamstring. And if that generates any pain, it means I need to dive deeper into finding out what's wrong with that area. I'll also check his quad tightness by seeing how far I can bring his heel to his butt, and the same on the other side. Again, this is another great way to check motion of the hip. So I already have a sense from doing it with the hip flexed to 90 degrees, and this is with the hip extended. And what I'm doing here is I'm feeling the greater trochanter with my left hand, and I'm rotating the hip. And wherever it's most prominent gives me an idea of the anatomy of his hip. So he has a little normal anteversion of the hip and fairly symmetric. So then next thing I do is I have Peter, I want you to lift up your leg off the table. Straight up, yep, and back down. And what I'm doing here, I want to see whether he engages his hamstring first or his gluteus maximus first. So I want you to do it again. Good, and back down. Do that a few times, go ahead. So Peter engages his gluteus maximus before his hamstring, and that's a good pattern that we often like to see. And that's pretty much it in this, that's pretty much it in this position. That's good.